Now, as far as genetics, people who have durable responses, again, are NPM1 mutated, we don't know why, and IDH2 mutated, which was predicted based on preclinical work from Ravi Majeti from Stanford, where they showed that this mutation makes cells particularly dependent on BCL2 as an anti-apoptotic factor. So these two cohorts are doing very well, and we know already that patients who have p53 mutations or complex karyotype, they're not doing as great. So the mechanism is not very clear right now. So I think that's being studied in several labs, but the data are clearly out there that these people would relapse earlier. So they would respond initially, but then they would relapse, and it's not clear what's the mechanism there. So in our center, we decided to examine the combination with 10 days decitabine, because there was a prior New England Journal of Medicine paper from WashU that reported that 10 days DAC is the kind of best therapy for p53 mutated patients. So we have our internal trial combining 10 days Venetoclax, 10 days decitabine with Venetoclax, which we will report at ASH this year. But the data look good, but we don't know as far as p53 status yet, because it's fairly early. We have recently done some studies on people who were relapsing after combination, HMA Venetoclax combination, and we did single cell genotyping. We haven't presented this data as of yet, but again, the RAS mutation came up as one of the prominent one, probably activating MCL1 signaling. So it's eventually all kind of, except for p53, which we don't understand, kind of comes down to MCL1 by different ways of activating its either transcription or protein stability through mutations such as RAS mutation or PTPN11 mutation, which is phosphatase controlling MAP kinase pathway. So we all hope that if we can find out like safe combination of MCL1 inhibitor, either direct or indirect, and Venetoclax, then we can cure a larger proportion of patients. And eventually we think it will be triplet with HMA, MCL1, and BCL2 inhibitor, because now we're moving in kind of multiple drug combinations in AML, much similar to what has happened in myeloma. And we think that we will have higher cure rates with this approach.